Hello, everyone. Thank you for joining us today for our webinar entitled MACRA, MIPS, and APMs, 2018 Participation in the Quality Payment Program. Today's presenter is Bruce Mackey, MCEDA Regulatory and Incentive Program Analyst. My name is Liz Jones, and I am today's moderator. Before we begin, I have a few housekeeping items to touch on. We will be keeping the phone lines on mute during today's presentation. If you have a question for Bruce, please type it into the questions box in your GoToWebinar interface. We'll take time at the end of the presentation to answer any questions you have. If for some reason we are unable to get to all of the questions, we will email you directly with an answer following the broadcast. We will also be posting a recording of today's presentation on our website, mceda.org. A copy of today's slides are available there now by going to www.mceda.org and clicking on the webinars link at the top of the page. Also, the presentation slides are currently available in the handouts section of your GoToWebinar interface. The information you will hear in this broadcast is current as of today and is only intended to be a general summary. Since federal and state policies change frequently, the best way to stay up to date on current requirements is to review the actual written law or regulations. We encourage participants to review the specific statutes, regulations, and other interpretive materials for a full and accurate statement of their contents. Today we will start out by giving you a brief overview of MCEDA and our various service offerings. Following that, Bruce will take over and provide you with an overview of the Quality Payment Program, focusing on MIPS program updates for 2018, information on participating in alternative payment models, and free technical assistance available to every program participant. Following the presentation, Bruce will take the time to answer program questions posed by the attendees. Housed within Alterum, we are MCEDA, the Michigan Center for Effective IT Adoption. Originally born out of ARA, and more specifically the HITECH Act, MCEDA is Michigan's regional extension center tasked by the federal and state governments with accelerating the selection, adoption, and meaningful use of health information technology to improve the quality and efficiency of healthcare in our state. To date, we have assisted nearly 6,000 providers across Michigan, impacting 1.6 million patients annually. Ranked as the 5th largest REC out of a national network of 62, we are also funded by the state of Michigan to assist any provider participating in the Michigan Medicaid EHR incentive program. MCEDA's health IT services include the following. Number 1, meaningful use support at any stage and year. Providers participating in the Medicaid EHR incentive program also benefit greatly by qualifying for state subsidized services that bring our top-rated technical assistance to you for only $200 per provider, a savings of 96% compared to commercial service rates. Number 2, security risk assessment and network security evaluation. Risk assessment is an embedded service within our meaningful use support, but if providers only need assistance with the SRA, for example, to satisfy the requirements of the Quality Payment Program, we offer it separately as a standalone service. The network security evaluation process is quick, simple, and with our tools and expertise, your technical security will be evaluated against known vulnerabilities. Contact us for more information. Number 3, attestation and audit preparation. If you are getting ready to attest and just need some peace of mind that you've crossed all the T's and dotted all the I's, or if you're one of the many folks who have been selected for an audit and need assistance responding, we are here to help. Number 4, consulting services. With our broad range of consulting experience, we can provide hands-on performance improvement assistance with common pain points like patient flow, productivity, efficiency, and staff patient satisfaction. Call today for a quote for services. Number 5, the Great Lakes Practice Transformation Network offers no-cost technical assistance to eligible providers in support of quality improvement initiatives and preparing for upcoming advanced payment model changes under the Quality Payment Program. Number 6, Our chronic care management program enables physicians to take advantage of the recently updated Medicare billing requirements for CCM services. We provide you with a dedicated care manager who works within your practice, helping fulfill CMS criteria to maximize your reimbursement potential. Contact us to learn more. And number 7, funded by the Centers for Medicare and Medicaid Services, the Quality Payment Program Resource Center for the Midwest provides free help to clinicians in small practices and rural or underserved areas as they navigate participation in a CMS quality payment program. Go to www.qppresourcecenter.com to join today. With that, I will turn things over to Bruce.
Thank you, Liz, and thank you everybody for joining me today to review the 2018 changes in the quality payment program. I'm going to do my best to stay on track and not veer too much off of the information on my slides. With any luck, I will leave some time at the end for some Q&A. If you have a question for me, please put it into the questions box of your GoToWebinar interface. I will get to as many of them as I can. If I do not get to all of the questions, I have your email attached to that question, and you will hear from me personally after the broadcast. So from a very high level, we are here talking about the quality payment program. We have the 2 tracks that if you've participated already in the first year in 2017, that hasn't changed. We have these 2 tracks again, either the MIPS track, the Merit-Based Incentive Payment System, or the Advanced APM track. That has not changed, nor have the program goals that are embedded. I'm not going to read through these. You guys just did. In the interest of time, we're going to move on, but I do want to draw your attention to the 2 websites at the bottom there for additional information. Really, you should be able to get all of the information you need on these on the QPP at these 2 sites. The CMS site, that's their main information site. It's also the site you go to if you're going to manually attest to the program. And then ours is the second one, the QPP Resource Center. I encourage you, if you qualify, to sign up for that service. We will work with you, kind of tailor a project plan. We have a team of folks that are experts in the program, just like myself, who can answer any question that you can throw our way. So we would be happy to assist you. And again, that is government funded, that is free to you. So what is MIPS? It is the Merit-Based Incentive Payment System. It combines multiple legacy Medicare Part B programs into a single program. We have the 4 performance categories that come out of it. We have the quality performance category, which is essentially just PQRF, and the quality side of the value modifier. We have the cost category, which we had that category last year, but it was not used. It is being used this year, and I'll touch on that in a little bit. That was essentially the cost side of the value modifier program. We have the Advancing Care Information, or ACI, performance category, which is really just another name for Medicare meaningful use. It brings in the same modified stage 2 meaningful use, or even the stage 3 measures, and really just scores them differently in this program. I will pause here again, as I usually do, and point out that the Medicaid EHR incentive program is still alive and well. If you have not captured all of those incentives and have already gotten your foot in the door before 2016 in that program, don't stop. Keep attesting to those Medicaid meaningful use attestations each year until you maximize the incentive dollars. You could still be getting another $8,500 per provider per year until you max out on that one. So Medicaid meaningful use is still alive and well. Medicare meaningful use has become the ACI, or Advancing Care Information, performance category. And we also have improvement activities, which is a new category. It's not part of a legacy program, but the activities that are contained within most definitely are not new. And a lot of you have quickly picked up on the fact that a lot of the activities embedded in that category are stuff that you've already been doing in your practice. So you just have to attest to the fact that you have had those in place during the program year, and you can get credit for that. So who is included? As we knew was going to be the case, there are no changes in the types of clinicians that are eligible to participate this year. The ECs, again, for 2018 are the exact same as we saw in 2017. So we have physicians, physician assistants, your nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists. So as a reminder, the definition of physician includes more than just MDs. It also includes the DOs, doctors of dental surgery, dental medicine, podiatrists, optometrists, and chiropractors. Now, those are all included in the definition of a physician. We do see a significant change in the low volume threshold for 2018. This is going to cause about nationwide about 500,000 clinicians who were eligible to participate, who needed to participate in 2017, are now going to be ineligible in 2018 because of a significant jump in the low volume threshold. So in 2017, that low volume threshold was the billing side, the Medicare Part B allowable claims at greater than 30,000 and providing care to more than 100 Medicare patients during the measurement period. That has significantly increased, as you see on this slide. That the 30,000 has now bumped to more than 90,000 in Medicare Part B allowable charges, and it's not greater than 100 patients, it's greater than 200. So we expect about 500,000 providers to get knocked out of the program as a result of that significant increase. So as a reminder, to be a MIPS eligible clinician, both of those conditions need to be true. So you have to provide care either at the individual or group level for greater than 90,000 in Medicare Part B charges, and provide care to more than 200 Medicare patients. If either one of those is not true for you or the group, then you're not MIPS eligible. So the exemptions, we don't see any change there. If you're a newly enrolled Medicare provider, if you just enroll to participate in Medicare in 2018, you are not a MIPS provider in 2018. You get to take the first year off, the first calendar year off, but you would be eligible in the next year. We just talked about that low volume threshold. So if you're below that low volume threshold, you are not MIPS eligible. You do not have to participate in this. And those that are significantly participating in the other track of the quality payment program, the advanced APM track, those folks are also exempt from the MIPS track. We also don't see any change in the definition of non-patient facing. So last year, and again this year, individuals, you have less than or equal to 100 patient-facing encounters during your reporting period, or groups, if it's greater than 75% of the NPIs are labeled as non-patient-facing, then the group would be called non-patient-facing. That doesn't change for 2018, but we do have this new category of participation called virtual groups that is available in 2018. I'm going to expand on that in a moment, but you can see it is possible for a virtual group to also be considered a non-patient-facing group. Other special statuses, we don't see changes here from 2017. The definition of a small practice that is not just MIPS eligible clinicians. It is determined at the TIN level. It looks at the number of billing clinicians. So you are defined as a small practice if you have 15 or fewer billing clinicians under your tax ID number. And the definition of a HPSA, or health professional shortage area, also does not change. We see some significant changes here to the performance periods. This is a big change from last year, at least for some of the categories. Under the quality category, last year it was a minimum 90 days, so you could report on your quality measures anywhere from 90 to 365 days. Making adjustments in those in that reporting period could significantly change the quality score that you get in that performance category. You are locked into a year of reporting. So your quality reporting period began on January 1st. If you intend to use or intended to do claims-based reporting, hopefully you were on the ball and had those G codes on your claims right from the beginning of the year. If not, you need to get that going now. It doesn't stop you from doing claims-based, but there's a chance if you don't start doing the claims-based reporting you're going to drop below the data completeness threshold, and I'll talk about what that is if you're unfamiliar later in this deck. The cost category, it existed in 2017 but was not used. There is some feedback that is still coming for last year to help you kind of figure out where you're at for this year and in the future. But we are using the cost category this year, and that is a full year of reporting as well, and I'll expand upon the cost category in a future slide. Improvement activities is the same as last year. It is 90 continuous days of having that improvement activity implemented. That is the same again for this year. You do not have to have those improvement activities implemented for the entire year. I think in a lot of cases it probably makes the most sense just to get them in place and keep them in place, but you can still get credit for it as long as you had the activity implemented for that minimum 90 days in this calendar year. And same with the advancing care information category, the ACI. It is not a year-long reporting period. It's a minimum 90 days there too. You can flex that. It can be above 90 days, just like it could have been for 2017. So that reporting period for ACI can be anywhere from 90 to 365 days, but 90 days at a minimum, same as last year. So the reporting options, we had 2 out of the 3 of these last year. We add a third one, as I've already mentioned. You can participate in the program at the individual level. So each NPI and tax ID combination is seen as a separate program entity. So if you work for more than one organization, each one of those organizations will generate a separate MIPS score for you, and your payments would be adjusted relative to that score under that tax ID. So that is one way to participate. You can also participate as a group, so 2 or more clinicians that are under a single tax ID can band together and form and report at the group level. If you do that, you are combining the data across all 4 of those performance categories into a single data set and attesting to that. That is at the group level. You can, if you're in an APM entity, when you see APM, you can think ACO or some medical homes models, particularly the CPC Plus model could qualify there. So you can participate at the APM entity level, which is group reporting as well. And we have this other category, this virtual group category. So the virtual group is made up of solo practitioners and groups of 10 or fewer clinicians who come together virtually. It doesn't matter the location or specialty. You're going to participate at the group level. So one way to think about a virtual group is it's almost like a mini ACO, and it kind of works similarly as an ACO does in group participation, where you have multiple providers from different tax IDs that are banding together to participate at the group level. So that is what a virtual group is, and I'll expand a little bit more upon that. The first bullet I just talked about, to be eligible, again, you can do it if you're a solo practitioner who exceeds that low volume threshold individually, and you're not a newly enrolled Medicare eligible clinician, or you can't be a QP, which means you are part of an ACO or perhaps a MIPS APM or a partial QP. And then the groups can also band together. So if you have 10 or fewer clinicians and you have to exceed that low volume threshold at the group level. Unfortunately, this isn't a way to kind of overcome that low volume threshold and get in. So just to be part of a virtual group, you still have to exceed that low volume threshold at the individual or at the group level in order to get in. Solo practitioners and groups have to go through an election process in order to form that virtual group. The virtual group election has to occur prior to the beginning of the performance period, and once you're in for that whole year. Unfortunately, you can't form a virtual group for the 2018 program year anymore. That election period was October 11th to December 31st of last year in order to form that virtual group for 2018. We didn't see a lot of interest in this, and I'm hearing kind of nationwide there wasn't a lot. Could be because folks just didn't know about it. There will be an opportunity later this year. I suspect the same election period will be used in this year for 2018 if you're interested in forming that virtual group for 2019. What else do you need to know? Well, essentially, any program policies that apply to the other kind of group, the regular kind of group, the kind of TIN, the tax ID level group, apply to the virtual groups. The same submission methods as groups apply. All clinicians within the TIN are part of that virtual group, so you can't pick and choose under a single tax ID and have some folks in a virtual group and some not. It's all or nothing. As I mentioned, you're going to aggregate all of that data, all of the scores to consolidate into a single group score as a virtual group. If you do form a virtual group and you're also part of an ACO, the ACO score is going to supersede whatever score the virtual group generates. So if you formed a virtual group but are also in the ACO, your virtual group score is not going to affect your payments. The ACO score is going to. Unfortunately, we didn't see any changes to the submission mechanisms. They are the same as last year. And one thing in particular we were hoping to see be a benefit to participants this year. Unfortunately, that has been deferred to at least year 3. Hopefully it is finalized for year 3. And that's the use of multiple submission mechanisms within a single category. It's something that's really needed under the quality category. It can be difficult to piece the best quality scores together because you are locked into using only one data submission method. This is particularly difficult if you are practicing in more than one EHR. It makes it somewhat difficult to marry that data together into a single data set, but the same problems you had last year with that, unfortunately, you're going to have to struggle through for one more year. Hopefully in year 3, we will see that finalized where you can use multiple submission mechanisms within a single performance category. So that'll make the quality reporting be a little bit easier for you. That would also allow you to do claims-based reporting on some measures and then do EHR level reporting on other measures. So with any luck, we'll see that finalized for year 3. That will have to stay tuned until the 2019 QPP final rule comes out, which won't be probably till summer that we see the proposed rule, and then it's finalized later in the fall. All right, we'll go through each of the performance categories and talk about some of the changes and a little bit of what stays the same as well. Under the quality category, we do see a change in the weighting here. Last year, it was worth 60% of the final score. 10% of that has been moved over to the cost category for this year. So the quality category is worth 50% this year. We have, again, over 270 measures that are available. You still have to select and report on at least 6. One needs to be an outcome measure or a high priority measure. CMS wants your data, so you get bonus points for over-reporting. They have the same specialty measure sets that were a benefit to some folks, others not so much, but those are still available to use as well. Data completeness, we see this increase a little bit, and we'll see it continue to increase over time. Just a refresher, data completeness, what that means is for each one of the quality measures, you have to apply it to a certain number of the patients to which the quality measure applies. That's sort of confusing. I'll use one of the quality measures as an example to illustrate this. Let's take the NQF 59, the main diabetes A1C outcome measure that is heavily reported. That looks at your population of diabetics. So it takes all of the patients in your panel who have been diagnosed with diabetes and then looks at their A1C level. Data completeness dictates that you have to apply the measure to at least, this year, 60% of those patients. So let's say you had 100 diabetics, diagnosed diabetics in your patient panel. If you only report on 50 of them, you're going to fail data completeness. And then you're only going to get a maximum of 1 point for that measure, regardless of the A1C control of the ones that you reported on. So you have to at least get to 60%. If you are reporting through your EHR, if you're generating a quality report, what's called a QRDA3 file out of your EHR, data completeness is automatically 100%. There's no way to kind of game the system if you're doing EHR-based reporting. Your EHR doesn't care who the payer is. It's going to apply that measure to 100% of those patients. But with claims-based reporting, there is the ability to kind of pick and choose which claims get that G code. I would suggest putting it on all of them, but you have to at least do it on 60% of them in order to meet the data completeness threshold. If you fail data completeness, you're going to earn 1 point for that measure. On a few places on these slides, you're going to see this highlighted, this burden reduction aim. CMS recognizes the difficulty that the smaller practices have in meeting some of these measures. They are often at a disadvantage to the larger practices that have a lot more resources that they can focus on this program. So throughout the program, CMS is looking for ways to reward the small practices and make it a little bit easier to participate. This is one area. So if you fail data completeness as a small practice, you would still continue to receive the 3 points. So it's a 3-point floor on the quality measures. That's the same as we saw for everybody in 2017. The lowest you could get is 3 points, no matter what the quality or data completeness was for 2017. That floor has been lowered to 1 point for the large practices, but it's still 3 points for data completeness, for failing data completeness in small practices. The scoring, again, we don't see a lot of change there. There's still that 3-point floor for measures scored against a benchmark. So if you don't meet the case minimum, or if the measure doesn't have a benchmark, the lowest number of points you'll get is 3. You get the bonus points for additional high priority measures. I mentioned that CMS wants your data, so over-report, give them additional high priority measures, and you can get as many as 10% bonus there. And as we saw last year as well, you can get a 10% bonus for what they call end-to-end electronic reporting. So that looks at the submission methods that you're using to get your quality data in. Claims-based reporting is not end-to-end electronic, but really if you're doing EHR reporting, that's going to be through your registry. It's going to be end-to-end. So some of those other submission methods would get you a 10% bonus there. Look out for topped-out measures. This wasn't as much of a factor last year. This becomes more of a factor this year. They are starting to cap some of the topped-out measures. So it's not all of the topped-out measures, so that's something else to be aware of. Topped-out measures mean that there are no longer meaningful distinctions in performance. So those that are performing seeming extraordinarily well, there's almost no difference between the low scores. So there are a lot of measures in that list of quality measures that are topped out or near topped out. There's not a lot of meaningful distinction. 6 of them have now been capped, and we're going to see this list expand from year to year. If they have been topped out for consecutive years, they're going to get added to this list. And so you can no longer get 10 points for great quality on those measures. They're going to be capped at 7 points. So again, as I mentioned, be aware that there's only 6 that have been topped out thus far, but there are a lot of other measures that are still topped out. They just haven't been topped out long enough to get capped. So even with those non-capped topped out measures, it's really hard just to get a good quality score because there are still not those meaningful distinctions. So in a lot of cases, you have to have perfect quality to get 10 points. And just slightly below that might earn you 3 points. And so look at that benchmark file that's available at the qpp.cms.gov website, and make sure that you're carefully selecting those measures, and you're not kind of hurting yourselves by focusing a lot on those topped out measures. So additional measures are going to get added to the list. These are the 6 that have been topped out for this year. So if any of these are ones that you used in 2017 or were planning to use again in 2018, be aware that the most points you can get, regardless of how good the quality is 7 points. Cost category. This is new to us this year. We did not use it last year. It is now worth 10% of your final score in 2018. There are 2 measures that are being used this year. I think we'll see them use some episode-specific measures in future years, but for now, this year, they're using 2 measures, the Medicare Spending Per Beneficiary, or MSPB, and the total per capita cost measure. These two measures are the only ones being used. And again, they're in the process of developing some additional cost measures. They weren't developed enough. We thought initially we were going to see some of those other ones used this year, but they backed off and realized they're just not ready to start scoring on them. They are using all administrative claims data for assessing you on cost this year. So there is nothing additional that you need to attest to. There's no additional data that you're going to send in to be scored on cost. If you can be scored on cost, they're going to use that claims data to do so, which understandably worries a lot of folks out there. Performance is compared against the performance of other MIPS clinicians and groups during the performance period. In a lot of these, they're using old data to compare against. They're not doing that for the cost measures. So the claims that are being used to assess in 2018 you'll be assessed against everyone else in the same performance year, the same benchmarks. So they're not using previous year data for that. If you can be scored on both measures, they're going to take the average of those two measures to create your cost score. If only one measure can be scored, it's going to serve as the performance category score. A lot of folks are not going to be assessed on cost because they just don't meet the criteria for it. If you need to have 35 cases to be scored on the Medicare spending per beneficiary measure and 20 cases to be scored on the total per capita cost measure. So if neither one of those apply to you, that 10% is going to shift back to quality. So you won't just not get a cost score. They will reweight that cost category, and the weights will then look much like they did last year. So instead of 50% for quality, if they can't score you on cost, it'll go back to 60% for the quality, and cost will go back to 0, just like we saw last year. But if they have enough data on you, they look at the number of the attributed patients. That will also keep, I think, a lot of the specialists will probably not get scored on cost for that reason, because it looks at the attributed patients that they look at who has submitted the most claims for a Medicare patient, and that's who that patient gets attributed to. So that's where we look at the 35 cases for the MSPB or the 20 cases for the TPCC. If enough patients can't be attributed to you, meaning that you're the primary caregiver for that Medicare patient, then you're not going to be assessed on these measures. We do also have some scoring improvements. One of them was wiped out by the Bipartisan Budget Act of 2018, but you can get some bonus points added for quality improvement. It is assessed at the category level, so it doesn't go measure by measure and provide these bonus points. They look at your quality score for last year, and if there was a significant improvement in your quality score for this year, you're going to get up to an additional 10 percentage points in that category. They were going to do the same thing for cost. They're going to look at cost last year and then a cost again this year. And if you improved, you're going to get some bonus points. But the Bipartisan Budget Act has delayed that. We might still see this come in future years, possibly after 2022. But for now, there will not be any bonus points for improvements in cost. I'll touch on, in a couple of slides here, I'll touch on some of the other things that the Bipartisan Budget Act does for the program, for this program year as well. All right, improvement activities. It is worth 15% of the final score again, which is what we had last year. There are more activities now. We had, I think, 94 activities last year. We've got 112 this year, so they've added some additional activities that are eligible for this category. Same weights as last year. The medium weighted activities are worth 10 points. The high weighted activities are worth 20 points. Those points are doubled for the small practices. So if you have 15 or fewer billing clinicians, the medium weight is worth 20 points and the high weight are worth 40 points. So a small practice could attest to a single high weighted activity and get full category credit here. They also changed a little bit of the definition of a patient-centered medical home, or the terminology that they used. It used to be you had to be certified PCMH in order to get the credit in this program. That created some issues, especially on the specialty PCMH programs that are out there. You might know it as the PCMH Neighbor program here in Michigan, if you're under the Blue Cross model. There's no actual certification for those folks, and so that created an issue with them not really being able to claim that credit in 2017. That's now changed. Instead of certified, the term recognized is now an equivalent term in this. So those neighbor program folks that are being recognized as being PCMH, even though they're not technically receiving that certification, would still be able to utilize the credit for that. And then if you're in a TIN or a virtual group, in order for them to be recognized as PCMH, we'd need at least 50% of the practice sites within that group to be PCMH for the whole virtual group to also be recognized as PCMH. As I mentioned, they have added some additional activities to it. We've gone from the 94 to 112, so you might find some new ones in there that apply to you. They have, just like last year, they continue to designate some of the activities that can provide some bonus points under the ACI category. We saw that as a way to get some up to 10% bonus points under ACI. If you are leveraging your EHR, your certified EHR technology to implement a handful of these improvement activities, I think there's around 20 of them that qualify. Those would earn you some bonus points. For group reporting, only one of the clinicians under a TIN has to have performed that improvement activity for the entire TIN to receive credit. Typically, we see these improvement activities applying to all of the clinicians in a tax ID, but if it's, as long as you have one and then you group report, the whole TIN would be able to claim that improvement activity. And it's the same thing under virtual groups. If you have formed one of those, I am honestly not aware of any in Michigan yet. And they continue to allow that simple attestation for improvement activities as well. You're just attesting yes. So if you get audited, you're going to have to prove that you had that improvement activity in there. So please don't lie. Don't try and game the system. Make sure that if you are attesting yes to that improvement activity, that you have the appropriate documentation. You could get audited 6 years from now, and you'd still have to prove that you had that improvement activity implemented during the program year. So make sure you got that proof. Advancing care information, it is again worth 25% of the final score. It's again comprised of the base score, the performance score, and the bonus points. We have 2 measure sets that are available, just like we did last year. So again, we see very little change from 2017 to 2018 in this category. As part of that burden reduction aim, they backed off on the requirement that everyone was forced to use only the 2015 certified version of your EHR. Thankfully, they backed off on that. I think if you listen to any of my webinars, I predicted that one last year. The implementation, the certification and implementation of that 2015 certified technology just didn't progress the way CMS hoped it would. So they had to back off on that requirement. So now you can use either your 2014 technology or your 2015 technology, or a combination of that in 2018. You can get a 10% bonus, however, if you are only using 2015 certified technology. The same 2 exclusions that we saw for e-prescribing and the health information exchange measures are in place as we saw last year. Thankfully, those got finalized near the end of the year. So it allowed a lot more providers to meet the ACI measures. So we have those same exclusions this year. If you prescribe fewer than 100 meds during your reporting period, or transition fewer than 100 patients out of your care in the reporting period, you could claim the exclusions for those measures again. No change to the base score requirements. For the performance score, they made a nice change to the public health requirements. Last year's version of this program kind of rewarded the providers that immunized and were actively engaged with the MICR, the Michigan Care Improvement Registry. and then you got some bonus points for other public health registries. They changed that a little bit to make it more fair to providers. So now it isn't just looking at the MICR to get that initial 10 points or that 10%. If you are reporting or you're actively engaged with any one of the many MIPS eligible public health or clinical data registry reporting agencies out there, you can get that 10 points for connecting to that first one. It could still be MICR, it might be MITRE, it could be the Cancer Registry, it could be Birth Defects. There's a lot of other national ones out there that would qualify, but if you're actively engaged, you get those 10 points for that first one, and then you get a bonus points of up to 5% for any additional public health reporting that you're doing. We see a little bit of change here in the exceptions, or if you're looking to re-weight the advancing care performance category to 0. We see some change here, especially for the small practices. So a lot of this is the same from last year. There's some automatic re-weighting of the ACI category, and again, that's going to shift. If you would like to, you could not be assessed under ACI if you qualify and have that 25% shift over to quality. For a lot of folks, overriding that automatic reweighting made a lot of sense because it is easier, it's often easier to get ACI points than it is to get quality points. So automatic reweighting is still in place for the hospital-based clinicians. The ambulatory surgical centers, nurse practitioners, your PAs, your CNSs, and your CRNAs all get an automatic reweighting. But again, a lot of these, especially the mid-level providers like nurse practitioners, have been meaningful users for years, and it just makes a lot of sense to still submit that ACI data, which would override this reweighting, and it would keep those points in the ACI category instead. We also see some reweighting through an approved application. We see a new category here. So if you are a small practice, if you have 15 or fewer billing clinicians, and you would like to not be assessed under ACI, you can apply for a hardship exception here, which would automatically take ACI out of the mix, and it would move that 25% over to quality as well. This could be a benefit if you're a small practice that just hasn't been able to implement your EHR yet. I know there's still quite a few of those out there that really just took a hit in the program in the first year because they couldn't score under ACI. Those folks can now apply for an exception and get that reweighted as well. We also see a new deadline. The deadline for submitting that hardship exception was several months earlier in the year in 2017. That is now, the new deadline is now the end of the year. So you've got all year to decide whether you're going to get assessed under ACI or not. They've also added one more place of service for hospital-based, the hospital-based clinician definition. They've picked up place of service 19 is also now counted. So now it's 19, 20, 21, and 23 get counted as hospital-based clinicians. This is a significant change, which we knew was coming. The performance threshold with that minimum final MIPS score that you had to get to negate that payment penalty has changed. Last year it was 3 points. This year it's now 15 points. The exceptional performer threshold hasn't changed. We expect that to be right around the 70-point mark as well. But the payment adjustment will change. Last year was supposed to be plus or minus 4%. The low end of that was still 4%. The upper end of that will not be 4%, just based on some of the pick your pace options and how easy they made it for clinicians to not get hit with the penalty. But the top and low end does tick up a little bit, up to 5% for this year, which we expected, and we will continue to see that move up from year to year. There are several ways that you can still negate that payment penalty with just a little bit of activity. If you're just looking to do that bare minimum, you don't have to fully participate. I highly encourage you to fully participate. But if you're just looking to do that bare minimum, you could do that by just reporting on your improvement activities. That would earn you at least 15 points there, and that would be all you really had to do, and you would avoid that penalty in 2020. You could meet the ACI base score. That's going to earn you 12.5 points, half of the 25% that the ACI is worth. And then if you submitted data on one quality measure that meets that data completeness, again, that means that floor is going to be only 3. You'd add the 12.5 you get under ACI, and that minimum of 3 that you get under quality, and that would give you just over the 15 points. You could meet that base score and submit one improvement activity. Any one of them would also get you over that 15 points. Or if you submitted 6 quality measures that all met the data completeness, because again, as long as you hit that data completeness threshold, the lowest score you can get on any one quality measure would be 3 points. So multiply that 6 times and you're going to get at least 18 points. So there are a few different ways to kind of do that bare minimum. We don't have the pick your pace options that we had last year, but essentially you can still sort of pick your pace by partially participating in the program, just enough to get over that 15 points. Because of the change in the performance threshold, we'll see what the points mean change a little bit. So you can see how the points are shaking out for 2017. Had to get at least those 3 points. Anywhere between 4 and 69 points would get you some sort of positive adjustment. We don't really know what those are yet. You're not eligible for that exceptional performance bonus. Anything above 70 gets you into that top end. So we see that shift up a little bit because the minimum threshold is now 15 points. But again, anywhere from just over 15 to just under 70 kind of puts you in the bulk of performers, and then the exceptional performers, they expect to be at the 70 and above again. So here's how the final score then calculates out for this year. We have the quality category at 50, cost at 10, improvement activities at 15, and the advancing care information at 25%. We do have a complex patient bonus, so you get up to 5 bonus points that are available for treating complex patients. They're using the HCC risk score to determine that, but you don't just automatically get points there. You actually have to participate in the program under at least one of the performance categories in order to get those 5 bonus points. We also see another part of that burden reduction aim. If you are a small practice, you have 15 or fewer billing clinicians, you will automatically get another 5 points added to your MIPS score. Again, they're looking for ways to even the playing field between the small practices and the larger ones that have more resources. So that is another way. Very quickly, I'm going to move through these APM slides because I've gotten a whole bunch of questions and I see I've only got about 10 minutes left. So not a lot has changed under the APMs, under the advanced APM track, which is why I'm not going to spend much time. I know a lot of you have heard me go through these slides probably 10, 15 different times last year. So really not much has changed. We still have the different categories of alternative payment models. MIPS APMs making up the vast majority of the APMs that are out there. These are the MSSP Track 1 ACOs. Close to 90% of the Medicare ACOs out there are MIPS APMs. That means you still have to participate in the MIPS track, but you get some good bonus, some favorable scoring under the MIPS track. Qualified medical homes, really all we have there, that is the CPC Plus, that gets you also into the advanced APM track. If you have enough risk built into your APM's model, it can become that advanced APM. That's really what I see as the main dividing line between a non-advanced APM, we'll call those MIPS APMs, and these advanced APMs, if there has to be enough risk built into it. You do need to be aware of the QP status. It is not enough to be in that advanced APM. You need to have enough patients or charges passing through that APM's payment methodology, which means the patients that are being attributed to that ACO need to be seeking care within the ACO. If they are seeking care outside of the ACO, you could not meet this QP status. The only way to get that 5% bonus, which is a part of the advanced APM track, is if your APM gets, or your ACO gets QP status. It was really not an issue in 2017. We heard very early on in the year that really all of the ACOs out there had reached QP status. Hopefully that's going to be the same for this year too. But we're going to see these thresholds increase significantly over the years, and I think in future years it's going to become hard for all of the ACOs to hit that QP status. So you need to ensure, again, that the majority of your patients that are assigned to the ACO or being attributed to the ACO are seeking care from the ACO, keeping those charges within that network of providers. Again, this year it's the same as last year at 25% of payments or 20% of patients. CMS will look at both of these calculations, and whichever one is more favorable to the ACO, that's the one they're going to use. But you can see in future years, even next year, it's going to bump up to 50% of payments. And that's going to go all the way up to 75%. So I think once we get a few more years into this program, it might be difficult for some of these ACOs to maintain that QP status, which would be terrible, because then you wouldn't be able to get that 5% bonus, which is one of the main reasons to get into that advanced APM in terms of the quality payment program. Advanced APM options. These were the same ones we saw last year. The majority of advanced APMs are the MSSP Track 2 and Track 3 ACOs, the next gen ACOs, which we have a few of those in Michigan, and the CPC Plus model. We do have an ACO Track 1 Plus that has achieved advanced APM status. There's a few others that are coming up. I think we will continue to see the advanced APM options expand throughout this year and in future years. Excuse me. The advanced APM options or the incentives don't change at all. You get those higher reimbursement rates, you get the 5% lump sum bonus, all the same stuff we saw last year. Same thing under the MIPS APMs. Nothing has changed as far as this criteria or who qualifies or that the advanced APM benefits don't apply. It's the same thing that we saw last year, so I'm going to, interest of time, buzz through these. We do see a change in the APM scoring standard. They made a slight change to how they are, which APMs they're going to apply this, the different weighting. So in 2017, the Medicare Shared Savings Program and the Next Gen ACOs had one set of weighting, but other MIPS APMs, and there's not a lot of them out there, but some of these other alternative payment models, they're called other MIPS APMs, they weren't being scored on quality. That has now changed. So now all MIPS APMs, no matter what type of MIPS APM it is, will all get scored on quality at 50%. They are not being assessed on cost because that is an embedded function of the alternative payment model. They're already being assessed on cost, so they don't get assessed a second time under the MIPS program. Get 20% for improvement activities and 30% for ACI. So I mentioned that first one. The second one here, they did add a fourth snapshot date. Unfortunately, last year, if you joined your ACO after the third snapshot, which was on August 31st, even though you were in the ACO for 2017, you didn't get into it quickly enough, and you are still you're MIPS eligible. You had to participate in MIPS just like a non-ACO provider did. They've added a fourth snapshot date now for this year. So if at any point you can get on your ACO's participation list, CMS will recognize you in this calendar year as an ACO participant, and you can take advantage of that track of the MIPS APM and the APM scoring standard. All right, Bipartisan Budget Act, we saw some changes as is typical with any legislation that is sure to get signed off on. There's a whole bunch of other stuff that gets tacked to it to ride on the coattails. So with the Bipartisan Budget Act that passed last month, we saw some changes to the quality payment program riding on its coattails. There's some mandated annual reporting on the resource use. That's another way of calling of the cost measures. So there's some mandated reporting, which you guys desperately need to understand that cost category. It slows down the increase of the cost categories weighting. Prior to this, we were going to see the cost category at 10% this year, and it was going to jump all the way to 30% as part of the mandate next year. The Bipartisan Budget Act changes that. It allows CMS to gradually increase the cost category. They can now, through 2022, can set it anywhere between 10% and 30%. So we'll find out later this year what next year's cost category weight is going to be. It delays the improvement scoring on cost. I mentioned that it is not, there will be no bonus points for cost improvement yet. That was set to start right away. That has also been delayed now for a few more years. They've essentially increased the transition period until 2022. They've also slowed down the increase of the overall performance threshold. This was a huge benefit to you guys, as was mandated in the original MACRA legislation. The performance threshold, what that minimum MIPS score needed to be, as of next year was going to become the mean or median of the prior year's performance. So what was going to happen, if not for this act, was we went from 3 points last year to 15 points this year to probably somewhere in the range of 70 to 80 points next year. That was going to make it very difficult for folks to negate a payment penalty because we just didn't have enough time to transition into those higher scores. So this now allows CMS to continue to set that performance threshold and ease us into those higher scores. So next year is not going to jump to 70 or 80 points. I suspect we'll be looking somewhere in the range of 30 points or something like that. We'll find out later this year what next year's performance threshold will be. Also this year, the MIPS program was going to pull Medicare Part B drugs into the calculations. The Act has now changed that as well. So Medicare Part B drugs are not going to be included in the MIPS program. There's free resources for everybody. If you are a MIPS participant or a QPP participant and you need help, please seek it out. The government is paying for us to help you. If you are a small practice, 15 or fewer billing clinicians, I urge you to, as soon as this webinar is done, go to qppresourcecenter.com and sign up if you have not already. If you are greater than 15 and don't qualify for that resource, don't fret. You can still get any of the assistance you need through some of the other organizations in Michigan. That is MPRO. They are ready and waiting to assist you. So there is free help for everybody. You are not on your own struggling through this program. Please sign up for the free help. We are waiting to help you, both MCEDA and MPRO. So you can contact me if you need some assistance with figuring out who you qualify for. If you are looking for information on MPRO, you can contact me as well. With that, I have not much time. I can stay a little bit beyond, and I'll answer as many of these questions I see as I expected. I got a litany of them, which is awesome. I will answer, I'll scan through and see what I can answer here in the few remaining minutes we have. And as I mentioned on the front side, if you pose a question and I don't get to it, I will email you directly and make sure that you get your answer. Every year, CMS makes announcements in May-ish. Do you anticipate any changes to MACRA for 2018 in May? How about 2019? I don't expect, I haven't heard anything on the horizon. I don't think we're going to see any additional changes for this year. I think any changes that we were going to get that affected this program year just happened with the Bipartisan Budget Act. That's not to say that CMS isn't going to surprise us and make some additional changes, but as of right now, I think everything that I just went over with you is what we are going to see for 2018, but we'll have to wait and see. CMS typically changes things, as you pointed out. So you can always check back with us. We'll keep you informed if anything changes. Can you discuss the NPI/TIN combo, as we have providers that went from an independent practice to a owned and was told that the penalties or uplift follow the NPI, not NPI-TIN combo? Looking for clarification to determine actions needed or other practices coming on board. The great question, Crystal. So the way this works is every NPI and TIN combination is treated as a separate program entity in MIPS. So if you work for multiple organizations, you are going to get a separate MIPS score within that organization under that TIN, and that score is going to affect your reimbursements at that organization. If you participated in 2017 at one organization under one TIN, as this example, but then by 2019 you are now working for a different tax ID, if CMS does not have a MIPS score under your new tax ID, they're going to look back into history and see if you did get a MIPS score somewhere else. that score is going to follow you to the new tax ID. So if you were not MIPS eligible and now you are, or you are in 2019 when the first penalties start to hit, if you couldn't have gotten a MIPS score, you're not going to get, you won't get penalized. But if a MIPS score existed for you, that one will follow you forward. If there was more than one MIPS score in that first year, CMS will take whatever the best one was, that's the one that's going to follow you to your new tax ID. So I suspect that starting probably this year, clinicians will probably start to put their MIPS score, or their best MIPS score on their CVs. So I think this needs to become part of that hiring decision. You need to ensure that the provider you're about to hire isn't bringing a penalty albatross with them. They may have not participated in 2017, and they're about to get hit with a 24% penalty in 2019 for not being a MIPS, for not participating in MIPS. You don't want to hire a clinician necessarily that is going to bring that penalty with them. So find out what those MIPS scores were for that first performance year. So I hope that helps to clarify that. Can you further discuss the multiple submission options? If there is a surgeon, they will have encounters in the hospital, surgery centers, and the ambulatory setting. It is almost impossible to find a vendor to combine those scores. How is someone supposed to submit their quality? That's a tough one, and that's why it was really hoping to see multiple submission options be an option this year. I am crossing my fingers that that gets finalized next year for this very reason. We have clinicians, especially surgeons, that are all over the place. We have providers that are practicing under the same tax ID, but at multiple locations, and each of those locations has a separate EHR. That creates a very difficult hurdle to overcome in terms of quality reporting, because you need to report on quality under each of those systems because they're all under that same tax ID. But you're at a huge disadvantage there because you need to be able to meet that data completeness threshold. So you can't just report out of one of those EHRs. You've got to make sure that you're reporting enough quality data across those 3 or more systems or 3 or more certified technology. But without being able to use multiple submission methods, it makes it very difficult. So there are some vendors out there. There is not a lot, as this participant pointed out. There are a few of them out there that have the ability to consolidate that data, but that's really the only way that it can be done. Is you need to find somebody who can take that quality data from those 2 or more systems and combine them into a single data set, because CMS will only accept that one single data set under that performance category. If this changes next year, which is what we were hoping to see for 2018, it's going to allow you to use different submission methods under that same category. So that's going to allow you to submit quality data, as long as it's on those same 6 measures, out of different EHRs. And CMS will essentially then consolidate that data under that one performance category. So it's going to make it so much easier for so many providers that are working under the same tax ID, but under different technology. So how does someone supposed to submit their quality? Unfortunately, I think some just won't be able to. And again, that is a huge disadvantage. They were hoping to see them patched for 2018. They, I'm sure, had very good reasons for not finalizing it for 2019, and they're sort of promising us that they're going to revisit it for next year. Does special APM scoring still apply in 2018? So I don't know what special APM is, but yes, as I mentioned, there is the APM scoring standard. I was probably talked about that. That question is hopefully answered, but yes, we have the APM scoring standard again to get those exact same benefits that we had for being in a Track 1 ACO, where you're getting full credit for under the improvement activities. For instance, we see that in 2018 again. I'm going to answer just another question or two. Thank you for those of you who are sticking with me here. Let's see if I can pick out another one or two, and then the rest of them I will answer offline. Will we know ahead of reporting what our cost score was when we are attempting to determine our final score? Unfortunately, no. And that's the cost category is causing a whole bunch of issues out there. I'm well aware it is difficult to get that cost information. There is still more to come. There is some mandated reporting that's coming in terms of cost. You can look back on if you were participating in the PQRS program. You can look at your QRURs. You can log into the QualityNet system and pull those past reports. The 2016 reports are there. Those have some cost data in it. Unfortunately, there's not a lot of great data out there in terms of assessing where you're at on cost. CMS is trying to get better on that. I know they're working feverishly to get cost data, the most up-to-date cost data that they can out to the providers. But as it stands right now, that lags way behind. It's difficult to really understand where you're being assessed on cost. So I know that's causing a great deal of anxiety out there. But when you log into the QPP attestation site, it's not going to have any cost data there yet. Hopefully in future years, we'll start to see some of that appearing, but we'll have to wait and see. But there is, as I mentioned, as part of the Bipartisan Budget Act, there's some mandated reporting that's coming as well. We should start to see around mid-year. They've promised us some MIPS reports around July or so, although we were supposed to start seeing those last year too and didn't. But hopefully we'll have some good cost data coming out if you don't have access to your QRURs. All right, let's see if I can find one more on here. For cost, if my specialty doesn't admit or discharge for hospital stays, my group would be omitted from this MIPS cost category and the 10% would be added to the quality measure, correct? That is correct. So if you can be assessed on cost, you will be. If they can, there's again those two measures. If they can only score you on one of the two, then that's what they'll use to assess your cost. A lot of providers, especially if you're not admitting or the specialists, just don't have attributed patients. You need enough attributed patients to you, then you will not be assessed on cost. And I suspect there's a lot of providers out there that will see that 10% cost get reweighted and shifted back to the quality category again. All right, folks, I had a lot more questions, and I really appreciate you sending these to me. You will hear from me offline, but I need to wrap it up for today. Thank you so much for joining me. This recording of this webinar will be available on the MCEDA website in a day or two. I will no doubt be rebroadcasting this again, as I did last year. So there will be another opportunity probably next month to hear me go through all of this again and any additional updates I have between now and then. But until then, thank you very much for joining today, and good luck with your 2018 QPP participation. And if you have any questions, comments, concerns, please reach out to us. We are here and eager to assist you, make sure that you're getting the best MIPS score that you can and that you're able to work through this very confusing program. So we hope to hear from you soon, and thanks and have a great day.